I'm Ashit Hedge. I'm an intensivist and physician at the Hinduja Hospital in Mumbai.
So what do we understand by beyond ICU care? Because we know that ICU is the best intensive care you can give to a patient.
No, sometimes you see in ICU is a place where there's a very good nurse-patient ratio. There's 24-hour monitoring, and critical ill patients obviously admitted there. But sometimes either for want of an ICU, shortage of beds, because other patients get sicker patients need to be admitted to the ICU. Sometimes we are forced to transfer out patients who are not necessarily the most stable to the wards. Now the wards are a different proposition altogether because the nursing ratio on the floors is much lower than it is in the ICU. The level of monitoring that they get on the floors is definitely much lesser than they would in the ICU. So obviously that's why a lot of physicians are not very comfortable keeping the slightly unstable patients in the floors, but it's not practical to put everybody in the ICU obviously. So therefore some kind of monitoring, remote monitoring on the floors definitely would be helpful, especially because nurses on the floor quite often are overworked. Quite often the ratio of patients to nurses is not the same as it is in the ICU. So they need to be monitored and preferably monitored remotely, which will also probably give the physician seating them a little more confidence in transferring patients out of the ICU. Our main aim is that once they're out of the ICU, we don't want them to be moved back. We want to pick up, or we at least want to, we only want to be moved them back. We want to pick up any deterioration in the condition much quicker than it is now. And that, I think, remote monitoring would probably be one step in the future, which will probably prevent these kind of catastrophes from happening.
How do you prioritize patient care and resource allocation in high dependency units?
No, we really, actually in our hospital, we don't have a separate obviously, theoretically, a patient who's a little more stable doesn't require that kind of intensive monitoring, is shifted to a high dependency unit. Ultimately, it's all about availability of beds. If you have the luxury of having enough beds, you really don't need to triage. The problem is when they are overwhelmed, when there's some kind of an epidemic like we had, then you have forced to triage. Now, it's difficult. It's a very difficult question to answer in one line. There are a lot of ethical issues, moral issues. So at the moment, honestly, we don't really triage that way. We just give first come, first serve. Honestly, we don't have any method. Other hospitals sometimes triage by age. Other countries. In our country at the moment, I think we just give first come, first serve. I don't hardly anybody ever goes by any other way of prioritizing, at least in our country. Rarely, if you have a patient whom you think is really not going to make it, or has an illness which is terminal, we might convince them not to get admitted to the ICU and make way for somebody who has a higher chance of getting care. But that's a rare situation. Most of the time we probably just give it to whoever comes first. I'm not sure that's the best way, but that's what we're doing at the moment.
What do you believe are the key challenges and opportunities in expanding critical care units?
Expanding critical care units, already I think the point is that obviously with healthcare becoming more and more sophisticated, with us doing more and more of high-end surgery, especially oncology, transplants, with advances in medical care, obviously the proportion of intensive care as opposed to the total number of beds is increasing. When I began, it was only 10% of the total strength used to be ICU. Now most newer hospitals have only 30-40% of their beds are ICU beds, probably because the kind of things that we're doing now are much more sophisticated, much more advanced, especially like I said, advanced surgery, transplant surgery, cancer surgery, which requires at least monitoring for a couple of days. And we are seeing many of these patients who've had these complicated treatments are developing severe complications. So obviously the need is increasing, and the proportion of ICU beds to the total hospital strength is definitely going to increase with time.
Thank you, sir.
Thank you.